All right. Well, good afternoon and welcome to this live stream. I'm Dr. Larry Patterson of Crossville, Tennessee. I'm the medical director of Eye Centers of Tennessee. And with me, I have Brooke Messer. Brooke is an optometrist with Vance Thompson Vision who focuses on the management of cataracts and glaucoma and refractive surgery. But in addition to all that, she routinely manages people with keratoconus and people with in need of post-surgical corneal care and all kinds of contact lens fittings. Yeah. And so we're going to be interviewing her today. Welcome, Brooke.
Thank you. Glad to be here.
So back in 2020, you had authored an article where you discussed a lot of steps about selecting and fitting scleral lenses and determining candidacy and all that sort of thing. And you know, regarding whether it's an existing diagnosis or undiagnosed keratoconus, we've had AvaGen out for about a year now. So how did that change things in your practice? How does that all fit in?
Yeah, so prior to AvaGen, we would do the topography and we would do our best to make the diagnosis and talk to the patient about, the management that we would have. From not having AvaGen to having it, the process of the contact lens fitting hasn't changed a whole lot. What shifts in being more aware of their risk for keratoconus, like let's say the topography, patient maybe has some scissoring on a reflex, or we're struggling to get them to a crisp 20/20, but the topography is questionable on keratoconus. At that point, being able to pull in the AvaGen testing and then understand their genetic makeup and their risk, it allows me to, kind of press the pause button and get them referred over for corneal crosslinking earlier than having to make that call on my own with monitoring for change or, waiting until we see a change in their contact lens, whether it be a corneal gas perm or a scleral contact lens. And, so if somebody has some questionable visual acuity, like I just can't get them there, they have high astigmatism, is it meridional amblyopia or is it keratoconus, and the topography is just a little iffy. Again, having that extra tool where if they came back at moderate to high risk, I'd probably feel a lot more comfortable sending them for cross-linking right at that moment, knowing that, hey, this is all signs kind of point to the keratoconus diagnosis. We'd get them cross-linked prior to the scleral lens fitting, where other times I may have waited until I was more convinced of the keratoconus diagnosis. I believe in cross-linking, and I think it's a super valuable procedure, especially in our younger patients. However, I don't want to make somebody go through a procedure that they don't need. And so it's really helped me justify that earlier cross-linking, or again, pausing this contact lens fitting and then resuming after they've healed from their cross-linking.
Well, give us just an overview, a quick explanation. Tell us what is AvaGen and how does it work?
Yeah, so AvaGen is a genetic test. We take a little cheek swab and take some tissue from the inside of or some cells, I should say, from the inside of the cheek. We send it in for genetic analysis, and it comes back as a relative risk score for the patient. So it gives us, how I like to describe it is if, your patient is in a room with 100 people, are they more like people who have keratoconus or more like people who don't have keratoconus? And so if they came back, right at 50, for example, 50 of the people in the room would have keratoconus and 50 of the people wouldn't, and they'd fall right in that middle, where if they came back at low risk, they would identify more with the people who don't have keratoconus than the people that do genetically. And so it's not a definitive diagnosis. However, it does help us identify their risk for development over time. Are they a young patient who already rubs their eyes? Is that something that's going to keep a tighter follow-up schedule versus they have a very low risk? Now, I do believe that somebody can literally rub their eyes to a point where they induce corneal warpage and corneal change. But just understanding the genetics and their risk really helps change the clinical management of their eye on top, in addition to what I'm doing with their contact lenses.
So you had mentioned the eye rubbing. You actually are at a position now where you can take this extra bit of information and sit down with them and say, seriously,
yep,
eye rubbing in your case is really a potentially dangerous problem down the road.
Yes. And I really do believe, and we see it, these patients pop their lenses out and the first thing they do is take, a knuckle or a finger right to the globe. And you're just, I'm uncomfortable in the chair watching them do that. And I can only imagine what they're doing at home unsupervised. So I do think that, eye rubbing is a super important discussion, but even more so in those that are genetically at a higher risk for keratoconus.
So how do you've got the patient, how do you discuss AvaGen? They don't know anything about this and they're not a optometrist or ophthalmologist. How do you go about introducing this concept to the patient?
Yeah, I would say that it's a twofold, there's two styles of conversation. One is I'm having this conversation with an individual who's interested in refractive surgery, and the cornea is, again, kind of iffy. The posterior float, maybe not, a little bit of elevation. The anterior cornea shows some inferior steepening, yet they still get a crisp 20/20. Where do they fall in that? And there's a lot to do with good alignment, if you're using your pentacam or whatever your instrument is to measure the anterior and posterior surfaces of the cornea. But when all things check out and there's still just that little bit of unknown, I like to go to the patient and tell them, we have more tests available that can tell us about your risk. And of course, we'll discuss, hey, if we go in and do LASIK and we ablate corneal tissue, if you were at risk for a condition like keratoconus, it could actually manifest from that treatment. And then I'll talk about, but hey, we can take this test. We can understand your genetic makeup. What are your fibers in your cornea? What are their roots like? What are they gonna? How might they respond to having LASIK done? And then I'll talk about how quick the test is. Just a quick cheek swab. We get the results back fairly quick, and then we discuss having the discussion between the two of us over the genetic results, as well as the opportunity to discuss with a genetic specialist on their results as well to help clarify. And that can be done with the three people, the genetic advisor, myself, and the patient, or just the patient and the genetic specialist. And so with that conversation, again, it's more so on, if we didn't have the test, it goes back to clinical judgment. And but if we do proceed, there's probably some risk because of this unknown. If we have AvaGen and they come back low risk, we can go in a lot more confident. Maybe we do LASIK instead of PRK. Or if we're, moderate risk, or, in between where we're undecided where they fall on that map of, more identifying with patients who have keratoconus or more than who don't, if they fall right in the middle, maybe we do PRK instead of LASIK because now it's just a touch safer. Or maybe we do nothing at all. It really depends on the patient and their comfort level at that point. Some will take zero risk, and others are that motivated to get out of their glasses and contacts that they're okay with some risk, knowing that their follow-ups need to be tighter with their eye care provider. The other population that we have a discussion on AvaGen is patients who have keratoconus, and we talk about their kids. So we can do a genetic analysis on the parent and then also on their kids. We can do it, genetics are genetics. So we could do it at age 5, we could do it at age 15. Those results aren't going to change, but it certainly helps when we can do it earlier, because that helps train the kids at home. No eye rubbing, frequent eye exams, checking that astigmatism, and maybe even having something like pachymetry done earlier in their life so we can catch the earliest signs of a keratoconus, and then do something like crosslinking do crosslinking to lock in their corneas.
Yeah, I never thought about that till just now. So we're talking about either someone who has, they have keratoconus, no question about it. And you've been treating them, however you're treating them for keratoconus, but start to say, hey, you may have brothers, sisters, children. We probably ought to consider having them come in and do the same testing.
Yep.
And so can you give for us some some maybe specific cases in your practice where this has really made a difference?
Yeah. So I have two cases that I think are worthy talking about. One was a gal who came in for a new refractive appointment. So she was considering having LASIK or PRK. All in all, she was a pretty decent candidate, except she had a little bit of inferior steepening on her cornea. Her pachymetry was normal. She was 20/20 through a refraction. I grabbed my retinoscope and it was just like slightly scissory. And then in the conversation of talking about the inferior steepening and, just explaining what that could mean, she said, "Oh, my sister has this thing called keratoconus." And I was like, pump the brakes.
Okay.
So then we talked about AvaGen, and we got her tested, and she came back, as you would expect, like more than moderate. And so her aspirations of LASIK quickly diminished once she understood her risk, knowing what her sister has gone through. And so being able to, bring that up to her, and just the mild discussion around that, triggered her awareness of her sister's diagnosis. So again, that's kind of fun to, what I would have loved to be able to do is, her sister is out of state, to have gotten her results to compare the two, but she came back, more than moderate again. So obviously there's some genetic influence in their family.
And in a case like that, did you guys go ahead and talk about cross-linking regardless of what she does long-term?
We had recommended, at that point, we didn't recommend cross-linking because her posterior cornea still looked pretty good. And she was
someone you'd watch once a year.
Yeah, I think I even told her that we should maybe check her every 6 months for the next couple of years. From a conservative standpoint, I don't know that we had to. She wasn't an eye rubber, and all in all, again, it was just a little bit of inferior steepening, and AvaGen was new to us at that point, so we were kind of like hyper aware and really enjoying, getting people tested and getting the results. And so she just happened to come in at a really good time where I was excited to test people and learn, what the results shared with us. Another case that I think is a good one is, I've had a longtime patient of mine. Probably I've been managing his eyes for about 10 years, and he has terrible keratoconus, pretty poor vision, even through custom contact lenses. And he was concerned about his son, because his son now has astigmatism in his glasses, just a diopter. His topography that was taken at their hometown clinic was regular. It didn't have the tomography, so I couldn't see the posterior cornea, but he was 20/20 through that astigmatism, myopic astigmatism correction. But of course, given his vision and the severity of his keratoconus, he wanted to know more about his son. His son was 11 years old, and we decided to test them both so that we could understand, the dad's influence on the son. And dad came back at like a 65 or 70, something, pretty, in my mind, like pretty telling, no wonder you have keratoconus. And his son came back at a 79, so even higher than dad. And so that put us on, ultra high alert, being only 11, with, new astigmatism in his glasses. Again, we're not doing anything. However, it does tell us that maybe he needs tomography scans more than once a year. Because you just don't know, especially with, dad's eyes, in my mind, on how, he's like barely passing a driver's test, even with the best scleral lenses. So dad is obviously wants nothing more than to halt keratoconus in its tracks as soon as we, were to diagnose it in his son. So it would be maybe interesting now to get mom tested and find out where she's at, even though she doesn't have keratoconus. So I think it just opens a really nice conversation to talk about, again, like testing other family members, siblings, because as an adult, your siblings may be thinking about LASIK. But as kids, we want to diagnose as soon as possible.
Now, this question just occurred to me, but have you had situations where you got back a test result and it was just kind of hard to believe and you did it again, turns out, this is very accurate, you get the same thing if you do it more than once?
Yeah, I mean, we've had some where we've tested twice and the results literally came back at 0.
Okay.
And that one's kind of hard, because you would think everybody has, kind of a smattering of genes, and that everybody's probably got to have a little bit in there, even if it comes back at like a 10 or an 8.
Right.
Twice on the same patient, they came back at 0.
Okay.
And I think, again, on the axial maps on a topography, it can be a little misleading. You can see that inferior steepening and maybe chase it a little too far and want to diagnose keratoconus when maybe it's an alignment issue in the instrument. And that was probably his case there, where he had some inferior steepening on the axial map. Elevation maps on both the front and the back of the eye looked pretty good, but we still did it. Just he was a low risk tolerance patient, wanted to know the most he could about his opportunity to have refractive surgery. And so we did our due diligence and did testing like that. So.
Okay. We had a question come in from the group, and they were asking what advantages does AvaGen provide community optometrists that don't have advanced imaging equipment in their practice?
I think it helps, let's say you don't have a topographer or you have maybe just a topographer and not a tomographer. By being able to do this test in the practice, it helps you decide on how quickly or how urgently we want to refer patients, like our young patients, they come back low risk. And it just gives us an idea of, again, like the urgency to test the family members, test the parents. If a parent comes back low risk, we worry less about the kids and those kind of things.
Okay.
So it helps you maybe keep the patient in your practice a little longer before we have to refer them on to cross-linking. However, all of it comes back to clinical management. If you're seeing a patient, you're not getting 20/20 and there's scissoring reflex, questionable Ks, then you should send them on, even if send them on for a corneal consult, even if you don't have the topography or even if the topography looks normal. Again, like clinical judgment rules all. This is just another piece to that puzzle to help you make the call when maybe some of the clinical presentation you're seeing mixed, yes or no diagnosis in your testing.
Okay. Another question that came through was you had mentioned earlier genetic counseling. Can I, as the doctor, can I speak with those people, or do my patients? How does that work? Just genetic counseling.
Yep. You can talk to a genetic counselor as the doctor. And so for my first 4 or 5 tests, that's what I did. I actually called and spoke to the genetic counselor before I called my patient so that I could hear the terminology that they were using, some examples like the 100 people in a room, just understanding the results, especially when they come back in that like 40 to 60 range, like right smack in the middle.
Right.
What is this patient's risk? Is it, like 50/50, or is it, how do I manage this patient? And again, it was very helpful to have, those first 4 or 5 patients and understanding, as we saw those results span from 0 to 100, how I interpret that data. And so yes, you can absolutely talk to the counselor first. And then they follow up with the patient if the patient wishes. And so usually what it looks like is I talk to the counselor first, and then I call the patient, and then I say to the patient, you have an opportunity to talk to a genetic counselor about your results. Would you like to do that? And if they say, yes, I would like to learn more, then you just send a simple request through the AvaGen portal, and then they reach out to the patient.
So you guys have been doing this for a lot more than most people have. So based on your experience, what, I guess operational recommendations would you have
Yeah.
for someone starting this out and wanting to implement this?
I think it's really helpful when you have more than one team member who understands the test and the description, what it tests for. Certainly, I think interpreting the results and having that discussion with the patient is between the patient and the provider. But taking the test, there's a little bit of paperwork to make sure that, it gets entered into the portal properly, doing the cheek swab and sending it off, and explaining the test itself, assessing relative risk for keratoconus. Those things are really helpful if you can have a team member do it, because as you can imagine, something like this would spur up conversation and questions. And so being able to have a team member assist you field, the softball questions, and then you can follow up with some of the more complicated questions. As a provider, it just helps you implement something new without, stealing a bunch of chair time from you.
And just real quick, you had mentioned the genetic counseling. Does Avellino, are they the ones that are providing that?
Yep.
Yeah, okay.
So it's through the portal, and then they have counselors that for you. Yep.
We're basically about out of time. Do you have any closing thoughts or something I haven't covered that you want to mention?
Yeah, I think we did cover most everything that I wanted to. I think initially the value that we saw in the clinic was, the patients who wanted to come in and have LASIK, assess their risk.
Right.
The more we talk about it with our patients who have irregular corneas, the more they are interested in their family members, in particular their kids.
Right.
And so I would, some people say, well, I know I have it, so I'll just assume my kids are at risk. But again, the more we explain and the more that genetic testing becomes the norm with like 23andMe and Ancestry and all of those things,
Right.
the more people appreciate just understanding what they're made of. And So I think there are, two very distinct groups, and that application is only going to grow as we learn more about, what it can do. And I know there's, some neat genetic testings coming down the pipeline through Avellino in eye care. And so I think it's going to be just a really neat way to continue to enhance the services we provide our patients.
Well, I think the present is very interesting, but the future is going to be even more interesting. So,
Yeah, for sure.
I want to thank Ophthalmology Management for putting this together, and Avellino for hosting it, and want to thank Brooke for being here with us and for
Thank
all the
you.
information. And with that, we have no more questions, so we'll close this out. And thank you guys all out in the audience, wherever you are. I know you're there. I just can't see you. But thank you guys for participating in this, and we hope to see you at one of these real soon in the future.
Thank you.